very much, Professor Khan. And I remind the audience that if you have any questions, please just type in on the chat box, and I will ask you on your behalf. So, and I before the question for the audience, and I have one question for Professor Khan. Yes, because as we know that there's always the learning curve for every kind of new procedures, and but you demonstrate many difficult operations in the robotic surgery. But in fact, I think that is not the first case you choose to do the robotic surgery. So, for the beginners, for those who want to transition from VATS to robotic surgery, what's the recommendation you will give that to be to have a less painful learning experience? Please give us some advice. Thank you.
And usually, esophageal surgery is the most complex, and they use a very so many types of different devices is necessary. So changing from abdomen to thorax and so operation time is long, and so I do not recommend to do the esophageal surgery in the beginner. Usually, for the beginners, the young surgeons recommend to do the mediastinal tumor surgery and lateral approach. It is very easy to understand the robotic system, and two, the device is very simple, and so I recommend is that, if you are have experience and have some confidence, then do a lobectomy. I recommend it, and then then you can do the subxiphoid approach or esophagus something. And however, the several experience is necessary. And the first one is that I emphasize is the speed. And speed there because the robot has three speed mode: the slow and moderate and the quick mode. And then in the first time, do not use the quick mode because you cannot control the robot arm precisely and the inexperienced status. So stay focused on the procedure and do not hesitate. Do not try to do fast operation, just to be safe way. And so speed, if you have any confidence, you can fully control the robotic arm. You can increase the speed, but before the time, just to be slow, maintain the slow operation. That's the two points that I recommend. And the thing that I say is to do not hesitate to use the seizure, because I think the seizure is the most important device in the robot surgery. In a very complex operation, I always use seizure, not the energy device or blunt dissection. Seizure can do everything, but if you want to use freely the seizure, it takes time. So when you can use the seizure freely, then you can think that I can do all of the surgery using the robot. Is that sometimes when the time point comes, you will be very happy because it's a big, really a good experience. That's some point that I told them. So in the first time, please keep in mind that the safety is the first one. You can control the robot very well, so you should always remember that. Yeah.
Yes, I also have the same feeling that my favorite instrument during the robotic surgery is the Seizure.
Seizures.
Yes, because of the Seizure, you can do very sharp dissection, and you will know the beauty. And the Seizure could also use as a hook if you want. So you can do different ways of surgery using the Seizure, and I think that's the most important instrument. I recommend you to learn about this. And there's another one because I realize that now your robotic surgery is almost the same number as VATS, maybe last year, according to your presentation.
Yep.
So, but you are working in a national hospital, so
Yep.
teaching must be a very important
Yep.
thing in your life. So how do you do the teaching for your fellows or residents about the robotic surgery. So what's your process of teaching?
Before COVID endemic, we our residents had regular changes per 2 months, and so in the first day of the second month, 2 months after new team comes, we sent them to the robot company to have a 1 day program for their education of the general physics of robots and some basic concept of robot, and I let them go and learn something about the robot. And but after pandemic, it was stopped. It's a very sad story. Probably someday it will start again. And then currently, I ask my resident to come to robot surgery, and then sometimes the second grade, the third grade resident to come to the robot room and do operation with me, just the two people, me and one resident, to do the operation, even the esophageal cancer surgery or whole procedure. Then they can observe watch the whole procedure of robotic surgery, and becomes the resident to feel very interested in the robotic surgery. The other way is currently I am now let the other people, especially the fellows, do the robot surgery in the first part of the robot or the closing, when after finishing the main part, I let them do the robot surgery and using the dissection in the first and some the end of the closure, suturing something, and I let the fellows do that. And then I expect they will do very good job. Really they do very good job. In the 1 or 2 times of experience, they start to do very nice work. So it's a way to expose the robot experience to the trainees, and so I am always trying to thinking about the education and thinking about the exposure to robotic program or robotic surgery. And maybe at the end of the COVID endemic, I think that we can establish a new education program, I think.
Thank you. And there's one question from the audience.
Yep.
That they are very interested in your lobectomy video. So for plasma control of pulmonary artery, do you need an additional port to application of the vascular clamp, or just apply from the utility port?
So no, I don't need a vascular clamp. That's all. The bulldog clamp is all. But currently I use a snaring using the plastic and snaring. It's a more convenient, and it's a less bulky. It's so easier one. But however, the angioplasty is not a very common the operation. As my experience that why robot shows a very low conversion rate is that I have some patients who had a very very large lymph nodes after neoadjuvant treatment is very obstructing the pulmonary artery. In the cases, that technique is very helpful, not to do a conversion. And so it's a very good way to do a very complex operation, even in the invading the pulmonary artery. I think the seizures is important also. Yeah.
Yes, seizures is always our favorite.
Yeah.
So there's I have one question about the sub-xiphoid approach.
Yep.
As you know, now it's also my standard approach. But after I perform maybe 60 to 70 cases, and we do some analysis that actually if you still put the intercostal port, patients still suffer from neuralgia.
Yeah.
So, and that makes no little difference when compared with the lateral approach in terms of long-term neuralgia. So the patient might have lower pain after operation, but in the long term, some of them still suffer from neuralgia. So that's the reason I try to do the single port uniportal robotic surgery, only the sub-xiphoid port. So and that's also the same reason that motivates you to do the uniportal robotic sub-xiphoid surgery.
So you mean the difference in the pain in the
Yes, because
comparing lateral and subxiphoid.
Subxiphoid.
Yes.
Yes, because subxiphoid approach, but if you put the intercostal port,
Yeah,
the
intercostal
patient
port.
still suffer from neuralgia.
Yeah.
Yeah, so the only way to prevent neuralgia is don't put any intercostal port.
Yeah, right.
Yes.
But my experience, I don't experience no neuralgia. I don't know why, but some surgeons argued about that it is not a true subxiphoid because you are making a intercostal port. But I cannot remember any patients who complain of neuralgia. And in the early time, in the just the operation day and 1 day after operation day, I think that their pain is significant. It's very similar to lateral approach. But after 2 or 3 weeks later, when the patients visit my clinic again, usually no patients complain of pain, any pain. So I don't think the neuralgia is a problem. But however, and why I'm doing the subxiphoid single port surgery is that if I do a subxiphoid single port surgery, the 0 day and 1 day pain is much lower than the multi-port subxiphoid approach. So patients are very, very happy on that. But there's no difference. It's after in the outpatient clinic, we cannot find any difference. But because at the day of surgery, patients are not painful. This make a very good experience to the patients, so patients like it. So I decided to do a single port surgery. However, sometimes I do a single port lateral approach using the single site system. And the single port lateral approach produces more pain than the subxiphoid. However, it is technically easy. Really easy, very, very simple operation compared to the subxiphoid approach. So sometimes I use it, but the pain level is slightly higher, but also it disappeared when the 2 or 3 weeks later, it becomes no difference. So my opinion is long-term pain, neuralgia is not difference, but early pain is somewhat difference. The subxiphoid single port is better than other approaches. Yes.
So you are doing the subxiphoid single port using the multi-port robot, right?
Right. Yeah. We don't have SP system. We put the 3 arms in the one hole. Yes, it's a crazy one. When I do the first case, wow, this is crazy one. But we experience around 20 or 30 cases. But so I think it's comfortable. I come to know how to manage the arm to reducing the conflict between arms. But in the early cases, it's crazy.
Yes. So I'm very excited to listen to your talk in the next time about your uniportal experience using multi-portal robot. And I think that must be very, very interesting.
Yep.
And the final question, because in Korean it's very similar to Taiwan, that when the patient chooses to do the robotic surgery, they need to pay everything. Yes, and so the difference of cost is not low, it's high. So now how do you choose between robot and VATS in your patient's clinic? So what's now your selection process? Or the robot is always the first choice?
So many Korean surgeons also ask me, how can you maintain so large cases robotic series? Because in their experience, if a surgeon recommend robot, patients left the clinic and never return again because of high cost. And I always talk to patients, my result, evidence. For example, looking at the robot surgery, conversion rate is lower, and the length of stay is 1.5 days less, and the complication rate 5% less. But however, I also talk to them about disadvantages of robot. That the operation time is longer, and it's a port is when I use the Roentgen surgery, I use 1 port, 2 port, maximum is 3 port. But when doing the robot surgery, I must make a 4 port. The number of parties is larger, and the cost. I also talk about the cost, and I talk them freely about based on our experience. Then I will let them choose. If you choose a best lobectomy, I can do that. If you can choose a global lobectomy, I can do that. So currently, half and half is half patients choose the robot, half patients choose the best. And I did not mention the previous data. In the previous data, the hospital charge is different. And robot patients stayed in a more high class room. So hospital cost is higher in robot classes. So we can expect the people, the patients who choose the robot is rich patients. They do not concern about the money. They want just a better operation. If although the difference is very small, the very small difference they can pay $1,000 or $5,000. That's the difference in our situation. So this is the way that I talk to patients. I always talk about it clearly and let them choose it. So that's the why I maintain the half and half. Yeah.
So what do you expect? Because now I think in the future there will be more than one robotic company. That will be the monopoly will no longer exist in robotic surgery. So, and what do you expect? What the future of robotic thoracic surgery? As the final question today. Yes.
Yes. So many companies they're introducing the new robot. So, for example, Medtronic is introduced Hugo in our country. Urologist in our hospital is doing some clinical trial to get the FDA permission, the Korean FDA permission, and then so the organization requires the Korean data using the Hugo. So they are doing some clinical trial. So we are going to purchase a different robotic system in the future. So I think the competition is always good because we can make a cost down, and the maintenance fee is relatively high for Da Vinci robotic system. I like the Da Vinci intuitive surgical, but however, everybody feels that cost is too high. So if we can have a more robotic company, the competition will grow up and the cost will down, and the technical the advancement, the speed of the technical advancement will be improved, and so there will be a very good situation for the robotic surgery, and we make a very good circumference to lower the threshold for the robotic surgery, and so I think it is very good. But however, the intuitive surgical has a very strong position in the market, so the current position will not be changed in short time. So we need time to have a good effect for the getting the other robotic company. But I think competition will be always better. Yeah.
Yes, and there's final question, but I think you've already answered that. They are asking again that how would you recommend initial cases to start with robots? So probably you have to repeat again.
Yeah.
What's your sequence of suggestion? First case with what, and then proceed to which? Okay.
And I already answered. It's a mediastinal tumor. Yep. But if you have an experience on mediastinal tumor, you are good at the best lobectomy, and the lobectomy may be good one. When doing the robot surgery, you can feel some problem. You can change it to best. Then no problem. And I had 1 or 2 cases when I did a lobectomy in the early series, and that's the way to do the step-by-step way. And in the later, you can do more complex disease, more advanced disease, everything you can do if you have confidence. Yeah.
Yes, and also fight the Seizure always. The Seizure is the best one
Yep.
in robotic surgery.
Caesar's mania.
Okay. So now we are at the end of our session. So on behalf of the TSTS, we thanks again for Professor Khan's wonderful lectures, and we hope to meet you in person, face to face, in the very near future, and to have some good wine and good Korean wine,
Yep.
Taiwan beer together.
Yep.
Yes, and thanks again for giving us an excellent talk.
Thanks for the invitation. Yeah.
Yes, and we have to close the webinar. And thanks again, and we'll see everybody next season of the TSTS webinar. And thanks very much.
Thank you.
And bye-bye.
Bye bye.